So, dear colleagues, we are now on the Medtronic Symposium. I have to talk about one of the best stents which we have on the market now. This is Resolute Onyx drug-eluting stent. It's very easy to talk about Resolute Onyx because at the morning session, Yves and Goran made great presentations regarding the EBC left main study, which was practically done with Onyx stent, which was chosen because of almost unique characteristics of this stent. The Onyx stent permits to very wide opening of stent struts and stent cells. So the access to the side branches is very easy and is optimal. Practically all stents in my practice, even with the diameters 4.0, could be easily overexpanded up to 6 millimeter and even a little bit more, as our experience with IVUS demonstrates. And actually, this is the only stent which has its own bifurcation study for the left main stenting with provisional approach or with two-stent approach. Also, there is a current analysis of, I will show you later, about the usage of Onyx stent in general bifurcation non-left main population. The bifurcations are very frequent. This is why we are here today. And in different registries and different statistics, it varies. The frequency of bifurcation varies between 10, 15, up to 30% of patients involved in the analysis. The bifurcation has a complex geometry with angulation between vessels and different diameters at the different parts of bifurcation. If something happens with one of the vessels involved in the bifurcation, there is almost always a consequence, which is at least some periprocedural myocardial infarction, or as it is very fashionable now to see it in myocardial injury. And it is difficult to achieve stent optimization just because of the other reasons which I already mentioned. 70% from the left mains and actually distal stenosis of the left mains are with a large, very large diameter, much more than 4 millimeter, which more of the conventional stents obey. And it is more important that actually more than 80% of all stenosis of the left main are practically distal left main stenosis, which is very challenging. The Resolute Onyx has several unique characteristics. First, this is a single wire design with oval shape. This oval shape of the struts, it is very advantageable about the wire crossing in direction of the side branch. It is easily visible on the angiography because of the platinum iridium coil. As I already mentioned several times, it is very easy to expand the stent with more than 20 up to 30 to 40% without compromising radial strength. And the results from the EBC left main were already presented in the morning from Goran Stankovic. The intention was to compare provisional stenting technique with planned two-stent strategy in randomized fashion. This is the patient characteristics for the European patients. It's a quite diseased population, taken into consideration that diabetes is almost 30%, and 30 to 40% from these patients had acute coronary syndrome. Side branch was stented in 22% of provisional strategy. This is not one stent strategy. This is a provisional stent strategy. So in 22% of this patient cohort, side branch was stented, while in the planned two-stent strategy, 94% of this patient received a side branch stent, and among these two-stent strategies, the most popular was culotte, and then T or input protrusion were the second one. The DK crush was performed only in 5% of the cases. These are the results. The cumulative endpoint of this study was neutral, with insignificant difference between provisional strategy and planned two strategy. But I have to mention that practically this is 1 year analysis, and in most of the analysis, the clear advantage of the one stent strategy and provisional T-stenting is visible at a little bit later time. So we will see what will happen on the 24 and 36 months follow-up. The death rate at 1 year was lower, and the MIs and TLRs were also numerically lower in provisional stenting. So that was the first randomized trial based on the EBC consensus, which compared provisional strategy with the intentional two-stent strategy. The results practically for provisional and two-stent strategies at 1 year were similar. And Onyx is the only drug-eluting stent with randomized data supporting applicability of this stent in the distal left main stenting population. The application of Onyx in general bifurcation non-left main study was assessed in this post-approval study, and the data from 205 patients were analyzed with the primary endpoint of target vessel failure, which was cumulative of events as cardiac death, TV, target vessel-related myocardial infarctions, or TVR. This is the characteristics. These are the characteristics of patient population. It is typical for such a type of studies, and these are the results for this study. As you can appreciate, almost 7% is the cumulative primary endpoint frequency at 1 year, which is quite good, with 0% of stent thrombosis and a very, very low target vessel revascularization rate. And I would like to finish with the application of Onyx and 2 year result in complex and non-complex lesions. This is a Korean analysis from the center of Sanjung Park. And as a complex definition was applied the European Society of Cardiology definition for complex. This means total stent length more than 60 millimeters, CTO, left main, severe calcification, more than 3 lesions treated, 3 vessels treated, and bifurcations with 2 stents implanted. These are the 2 year clinical outcomes. As you can appreciate, there is no significant difference between complex and non-complex lesions results at 24 months, including the MACE rates. It is interesting that the stent thrombosis was less in non-complex lesion, but this is not surprising. But these differences were not significant. And these are the Kaplan-Meier curves. You can appreciate that all the parameters, the target lesion failure, cardiac death, target lesion MI, and TOR were practically non-significantly different. And as a conclusion, I could state that the Resolute Onyx is one of the most appropriate stents for treatment of coronary bifurcation lesions, and it demonstrates excellent and durable results in non-complex and complex lesion subsets. Thank you.
Part of this symposium is going to be some cases that we have completed with the Onyx Resolute stent. I would say that this is the stent that we use very often in our practice. And Dori very well mentioned how the characteristic that these stents have and all the advantages of these stents. What we used, and usually with the Onyx, and what we used in the case that we just finished is the flexibility of this stent, because it is you can inflate it up to 7 atmospheres, and then you have a half a millimeter below the balloon diameter, which gives you a lot of comfort when we are treating patients with a big mismatch between the proximal and the distal part of the vessel, usually in bifurcation. This is case number 1. We're going to probably keep to only to this case for the sake of time. This is a male, 76 years old, and he is presenting with stable angina, with left main disease and multivessel disease that was proven in another hospital. The patient has multifocal, let's say, atherosclerotic disease, because he has severe stenosis on the left carotid and let's say a borderline lesion on the right carotid artery and peripheral artery disease. Nothing special. You can see the ejection fraction about 50% with inferior and lateral hypokinesia. What we have here, and you can appreciate, it is a left dominant, and you can see the circ is occluded approximately, almost occluded, or this is something like a thrombus, and you can appreciate it in the views which are cranial views, that there is a shape and appearance of thrombus. There is a distal disease, peripheral disease, and there is a proximal disease on the LED. So the patient, of course, this is the right coronary. It is subtotally occluded, but this is not that big artery. It is probably a small PD coming over from there. And on the right, you can see the severe disease circ and this appearance of just full appearance. Probably it's a thrombus, which is not that fresh. I told you that the patient is coming from another hospital. We have a syntax score 47, and the patient was scheduled for propose surgery, but the patient refuses, so we have to do something. And we started PCI of the left of the circumflex. What we have here is, of course, we started with CTO guide wire because it was not possible to go with a normal wire. You can see that the wire is going in the, not that, in a direction probably subintimal. On the lateral wall, this is a CTO polymer jacket wire with, you can see here the microcatheter. We just insisted, and finally we succeeded to go into the woman after several attempts, and we went into the distal lumen of the circ. What we did, we could go into the marginal, but it was not possible to go into the we went into the circumflex, but this margin was not possible to cannulate it in a normal way, so that's why we use a dual Woman microcatheter. And finally, here you can see the cannulation of both big vessels. Of course, the wire into the AOD. You can see the flow is almost TIMI 0. Predilation with 2-point balloon, and after that implantation of this from the first marginal to the proximal segment of the left circumflex. There was a dissection that was in the proximal part of the circuit, which is involving the distal part of the left main. And these are the procedures. This is the result after the stenting here, and after that we have this not very good result with some flow limitation at the proximal part of the not stented part, and a compromise of the circ, which is a big one. What we did, we go for stenting from the left main AOD to the circ. This is the stent. As I told you, this is implantation of 3.5, 38 millimeters. This is Onyx Resolute stent. And this is positioning of the stent in the caudal, positioning of the stent, the osteal part in the in cranial, and this is the inflation of the stent. Next is the result that we have. Of course, this is a suboptimal result of the ostium of the circ, and this is after kissing with and predilation with 2 balloon in the direction of the circ, and pot with 3.5 balloon. Of course, we cannot accept this result for this big vessel. That's why we went for a 2-stent strategy. This is the rewiring of the vessel, and on the second image on the right, you can see that we are preparing for TAP. TAP is done with 2.5 by 50 millimeter, again from Onyx stent, fine kissing balloon, and pot at the proximal part. This is what we have as a result of the circ. I forgot to mention that distally we did a bone inflation because the vessel was diffuse disease, and in this lesion that you see here at the distal part of the stent, we accept it as acceptable result. We define it as acceptable result. You can see there is a compromise into the AOD osteum, so we decided to, and the AOD is disease, we decided to go for treatment of course of the AOD. What we did is rewiring, and after that we did some predilation, and we again go for a TAP. This is a stent 3.5 by 30, which we implanted into the osteo part of the AOD, and here you can see the positioning of the stent at the ostium of the AOD. We have done it in spider view, and this is the process of making a kiss between the balloon from the stent and additional balloon 3.5 non-compliant. Finally, it was optimized the proximal part of the stent with 4-row balloon. I mean, this is pot the distal part of AOD, and additional stent was put in distally because there was a lesion that was not covered by the stents, the proximal part of proximal stent in AOD. And these are these steps of the procedure. And finally, this is the final result, which is quite, I would say, acceptable for this patient. He was planned to come for the and to see the and assess the lesion on the right coronary artery, which is before that he was yes, it's a good result. In fact, this result we did it after the congress in. What was the previous congress in? I forgot, right? But we did it with Ravi Nair, where it was.
Yes.
Nevertheless,
2 years ago, just before COVID.
4 years, just before the COVID, yes. And It is a nice result, and I think we estimated this patient with non-invasively, and there was not a big ischemia from the right, so we left him. Another case, do you have a time or we should skip?
We have,
Well,
but I don't have.
yes, I will go fast here. This is a male, again, but a younger male with a stable angina, and he came for acute coronary syndrome. For acute coronary syndrome, with unfortunately on this age with a big history of ischemic heart disease, and this is what we found. In fact, this is part of the procedure, and this is what we found, and this is the angiography. This is the circumflex, this marginal with very severe stenosis, for which was the reason and the culprit lesion for the acute coronary syndrome. And you can appreciate in the previous scene here, this is the right coronary that was already stented before all this his history in our hospital. So stent of the right, acute coronary syndrome, and this lesion on the marginal that was stented, and this patient is coming from here for the AVD, which you can appreciate is a coolit, and we have double injection, contralateral injections in order to treat this CTO, which is not that long, but the vessel is diffusely diseased proximally and distally, and you can appreciate in the next images that there is an unpleasant side branch. There is a septa or the distal part of the occlusion, of the proximal cap of the occlusion. So you can appreciate the microcatheter. This is probing just with Gaia 1, but it was not possible to penetrate. That's why we changed on the next, on the right side. You can see that we started and tried with ultimate wire, which penetrated the cap, and finally we were able, this is the advancement of the wire, this is the distal cap, and finally the wire went distally into the vessel. Of course, it was exchanged with workhorse wire, and you can see here, this is the result after ballooning with 2O balloon. Appreciate that AVD disease, and we should go for treatment of the left main. And finally, these are 2 Onyx stents. The final result, just to go further with the case. This is the final result after 2 Onyx stent, one in the distal part, one proximal, which is 3.5, which is which is 4.0, inflated up to 3.5 distally, and after that optimized with a 4.0 balloon. Of course, we have for some reason I cannot play this movie, but this is the final result. Of course, we have done optimization of the stent with non-compliant balloons, and we have for some reason it is not going. We have done optimization of the stent with non-compliant balloons, and of course kissing and pot in the proximal in the left main, and this is the final result. Thanks for your attention.
I want to say just a few words for the stent. I think it's a really good stent, one of the best on the market.
It's a proven stent with proven efficacy, and we're really using it quite often, because especially in bifurcation, and this is the indication, in fact, for these stents according to the National Health Insurance, and it is very plastic, flexible, and one good feature is that it is well seen on under fluoroscopy. And something else, this is flexible, and it is of course an impression, but it is very flexible, and it is very well adapts itself in very tortuous arteries without straightening the vessel. You just can inflate it, and it is almost following the same course of the vessel and preserving the curves, which is very important in some cases. But this is what we...
I fully agree. It's probably the stent that we have really strong data for the bifurcations, but also the deliverability of the stent. It's excellent, and it's a matter of choice in a really complex and calcified
Just as a
lesions.
comment, and I will ask, excuse me, all these experienced guests from our faculty, Yves and George, but you should have at least 2 or 3 different types of stents at your shelf. This is what I think, and we are trying to do this in our CAD lab, because this is the same with balloons, because in different cases and different scenarios, sometimes you need some of the features of the stent just to fulfill your demands, or to, let's say, in more simple to do the job in some special cases. Thanks.